Yes, good afternoon, Dr. Greer. My name is Noel Boyle. I'm a cardiac electrophysiologist at UCLA Medical Center in Los Angeles. Yes, SICD is short for subcutaneous ICD. These devices were FDA approved in 2012 and they've got EU approval in 2009. So they've been on the market in the US for just about a year. My understanding is that Cameron started about a decade ago, and some of the impetus for developing these subcutaneous ICDs were problems associated with the transvenous ICDs. In particular, there were implant potential risks such as pneumothorax, collapse of a lung, or perforation of the heart with cardiac tamponade, which would be implant-associated complications. And then the transvenous leads over the last decade have had a number of recalls, particularly due to fracture of the leads or breakdown of the insulation of the leads from various companies. In addition, there are groups of patients who are either high risk for the transvenous lead implants or patients who simply can't have it. For example, patients with some of the complex congenital heart diseases, or patients with occluded venous systems. There is no way to implant, or no route to implant, a transvenous lead in the heart. And then in addition, there are some very high-risk groups, for example, patients who are at high risk of infection, who have immune disorders, or have had splenectomies, or patients who've had indwelling catheters, or patients on dialysis would be groups of patients who are actually high risk for infection associated with implanted leads in the venous system. So these were some of the motivations for the development of the sub-Q device. Well, we actually have, at UCLA, we haven't actually implanted one of these devices yet. We have screened a number of patients for them, but actually haven't found a patient, either a patient who wished to proceed or a patient who is suitable for some other reason. So the patients particularly are patients who do not want to have a transvenous system. So again, patients with congenital heart problems or occluded venous systems who have no route to the heart, and then patients who are at high risk of infection, who have indwelling catheters or on dialysis. These would be the patients that are optimal candidates for the device. But there are some very significant differences in terms of size and weight compared to the current transvenous devices. There are several differences between the subcutaneous device and the transvenous devices, which of course have been around for 25 to 30 years. The subcutaneous device currently is much larger than the transvenous device. The subcutaneous device weighs about 145 grams. The transvenous devices weigh about 70. The subcutaneous device size is about 70 cc's, again, more than twice the transvenous device. So it's a significantly larger device. One reason for the larger size is that it needs to have greater capacitor storage, so it can deliver a shock of up to 80 joules, as opposed to the transvenous devices, or the pectoral devices more accurately, who really can defibrillate almost invariably with a shock less than 40 joules, so they need a smaller capacitor size. The transvenous device also is implanted on the left side of the chest wall, about the fifth rib between the anterior and mid-axillary lines. So it's about where the elbow touches the left chest wall, or just a little bit above that. The transvenous or pectoral devices are implanted up on the left upper chest wall, just under the clavicle. So there is a significant difference in both size and location of the device itself. The transvenous devices need just one incision, where the device and lead can be all implanted at the same time. The subcutaneous devices need up to 3 incisions, so the incision in the left chest wall, an incision at the lower border of the sternum and at the upper border of the sternum, in order to thread the lead through to its position just on the chest wall, just parallel and left lateral to the sternum. Yeah, so a couple of features of the standard pectoral transcutaneous device that are not available in the subcutaneous device. One is overdrive pacing for monomorphic ventricular tachycardias, and it turns out that about 80% of monomorphic ventricular tachycardias can be terminated with overdrive pacing, so that avoids the need for shocks, and that's a significant benefit to the patients. That is not available with the sub-Q device because it doesn't have a direct connection to the heart. Additionally, if a patient needs bradycardic pacing for sick sinus syndrome, in addition to their ventricular arrhythmias, then the subcutaneous device, apart from a short period of pacing after a shock, cannot provide continuous bradycardic or dual chamber pacing. A third pacing issue is biventricular pacing in the setting of heart failure, which again would not be available with the subcutaneous device. And lastly, one other benefit of the standard devices or the pectoral devices is that many of the devices can measure fluid status of the patient by looking at lung impedances. And so they can give information on the patient's fluid or volume or heart failure status. And again, this is a feature that's not available, at least in the current first generation of sub-Q devices. The real infection risk for standard pectoral transvenous devices, for new implants, it's about 1 to 2%. And for device changeouts or battery changeouts, it's about 3 to 4%. The risk of occlusion of the venous system is probably about 1 to 2%, and that's common to find that, but usually that has no clinical sequelae because it's just located in one subclavian vein or the other, and the patient usually develops collaterals. The risk of perforation of the heart or cardiac tamponade at implant in experienced operators, experienced institutions should be well under 1%. There is wide awareness in the EP community and even in the general cardiology community. The initial trials were reported in New England Journal of Medicine in 2012 as a lead article. So it will be well known to most cardiologists and certainly all EPs. There have been a recent review in Journal of the American College of Cardiology, JACC, indicated that about 2,000 devices so far implanted worldwide, of course probably with the majority in Europe and outside of the US. I don't know which centers are particularly have gained a lot of experience. I know actually one of my colleagues in San Diego has implanted a number, Dr. Balat. There is a significant learning curve associated with implanting these devices, although it's actually probably very short for people who are experienced implanters, according to the recent review in JACC, Journal of the American College of Cardiology. And there has been a concern with the potential of subcutaneous or erosion or skin erosion at the site of these devices because of the larger size, obviously particularly in smaller patients. There has also been a reported infection rate of about 5 to 6%, which is actually higher than the standard pectoral transvenous devices. But again, this represents the early experience with the first generation device. No, I haven't seen any change from the company, but the company has provided training to EPs and implanting physicians throughout the country over the last year or so. And I think the company is promoting it as a viable alternative for some of the groups of patients that we've talked about. In terms of the cost, it's very similar to what we would classify as a single-chamber transcutaneous device, which typically is about $20,000 for the system, for the transcutaneous single lead system. And for the sub-Q device, I've been quoted a price of $23,000. So it's very much in the same price range. Just one other comment I'll make is on the issue of inappropriate shocks. perhaps I could I'll talk about that for a second. Inappropriate shocks are a big concern with all devices. An inappropriate shock is where a patient gets shocked either not for ventricular tachycardia, so either for a fracture of the lead or some malfunction of the device, or for a supraventricular tachycardia, most commonly atrial fibrillation. This can run up to 25 to 30% with the transvenous devices, the pectoral transvenous devices, and is running at about 15% with the subcutaneous devices. So it is an issue, particularly in younger patients who may end up getting shocked for a tachycardia that's not ventricular tachycardia, or perhaps more rarely with these devices, the subcutaneous devices, more rarely for actual lead fractures.